of April 2021, but let's face it, no one's going to remember if they're a year old. And oh, look, my big microphone's in shot. Let's get my big microphone out of shot. And also, I'm guessing that Tuesday in April 2020 wouldn't be the 6th. So I think she's made a mistake with that. I think it's 6th of April. So I think these are the right questions. But anyway, what the heck? If they're not, I thought I was going to have to come on and just say there's no questions and just wait for someone to ask a question. But mercifully, I've been spared that. And I've got some questions. So let's get into it. Come on, stop messing about. Right. First question here. What it says is, what's the difference in a cyst and a lipoma? Well, basically, cysts and lipomas, a cyst and a lipoma would be what we would call the differential diagnosis of a lump that's underneath the skin. And so that would be differentiated from a lump that's on the skin. A lump that's on the skin would be something like a mole or skin cancer, or something like that. So these are lumps where the overlying skin looks normal. So if the skin looks normal but there's a lump underneath the skin, then the common differential diagnosis is a lipoma or a cyst, and they can occur anywhere on the body. From your point of view as a patient, the difference is slightly academic. It doesn't really matter because they're both benign. They both don't cause you any harm. The cyst behaves slightly differently in that a cyst can get infected and get inflamed and get bigger, and then it can burst and get smaller and disappear, and then it usually comes back again because the cyst wall's there. A cyst will often have a little hole called a punctum, a little hole where it communicates with the skin, but not always. So if there's a little punctum there, then it's more likely to be a cyst. And if it gets infected and gets bigger and inflamed, and certainly if stuff comes out, it's more likely to be a cyst. A lipoma is a fatty lump, normal fat, so nothing worrying about it, nothing cancerous or anything like that. Normal fat, but just too much of it in one area. And if you're really interested in telling the difference, you can tell the difference because a cyst is attached to the skin, whereas a lipoma is a subcutaneous lump, so it's underneath the skin. And that can be one of the challenges with lipomas. Lipomas can be different sizes. They can be, you can get quite large lipomas. And lipomas, it's hard to tell where they are, as in how deep they are, just by feeling them. So you feel a lump, but it might be quite deep. And it doesn't matter quite so much in areas where you haven't got that far to go, like the scalp and things like that. You often get lipomas. Hands up. Hi, Wendy. Nice to see you. You also often get lipomas on the head and on the scalp, and there's not far to go, but they can be quite deep even in the layers of the scalp. Whereas if you have it on your tummy or your buttock, being a classic example, then they can be quite deep. So that can be a bit of an issue because it can be a bit more difficult to find them because you can sometimes have to go quite deep. And if you are going deep on somewhere like the buttock or the abdomen, you might be thinking, oh, do I need a general anesthetic for this rather than a local anesthetic? And so if it is a lipoma, there is sometimes an indication to do a scan to get an idea of the depth of it before having the surgery and the extent of it, just so you know what you're setting yourself up for. Whereas a cyst would always be just right underneath the skin. The cyst is right there underneath the skin. So they can both be removed. They're both relatively simple to remove, and you can usually be removed under a local anesthetic unless it's a large lipoma. So yeah, that's the difference between a cyst and a lipoma. Now, Recover compression, sorry, has sent oh, you've retracted it. Yeah, sometimes I think if you press a button, I'm not sure what it is, but there's a button somewhere that it actually asks you to join, and you can join. We can do split screen. Oh, Joe, Molly's, Sophie and Dolly's here. We can do split screen if you want to join and talk, but I think a lot of people ask that but don't mean it. But it is something that which we can do, and if anyone does want to join from the comfort of their living room and ask a question, then that is a feature that's on Instagram. I don't know if you can do it on Facebook, can you? Oh, hold on a minute. Amy's asked something. Amy Summer Bonnie. Hey, can you do a mummy makeover and arm lift at the same time? Oh, blimey, O'Reilly, Amy Summer Bonnie. Well, I think I might have said this last week. Can you or should you? So can you? Yeah, you can. You can do anything, you know. But I think a mummy makeover and an arm lift will be a lot to do at the same time. It depends a little bit about what the mummy, because there's mummy makeovers and there's mummy makeovers. So, you know, some people will have who'll be quite slim, just got a bit of excess skin in their abdomen, and maybe, you know, just having a tummy tuck, whether it be a full or a mini. Whereas other people will have a bit more fullness there, a bit more skin there, maybe a bit on the sides, on the hips, maybe need a bit of liposuction on the hips. You know, that's potentially a bigger operation than the first one. Similarly with the breast, you might just do breast implants, which takes about an hour, or you might be doing something like a breast reduction or a breast lift or a breast lift with implants. All of those are sort of 2.5, 3 hours. So if you're at the lower end of the ops that you're having, so if you're having like breast implants and a smaller tummy tuck, either a mini tummy tuck or a smaller full tummy tuck, then maybe you could combine that with an arm lift. But I think in general terms, an arm lift and a breast procedure and a tummy procedure would probably be pushing it, Amy. I'm going to say I think it would be pushing it. And certainly at the moment where we are still a bit twitched about length of time of surgery, although we are coming out of that and there are green shoots of recovery, as they say, looking in terms of the length of surgery that we can do. But I think, Amy, that's a lot to be doing, a mummy makeover and an arm lift at the same time. I think that'd be a lot. But here we go. I'm booked in at the end of the month. I feel I'm going to need a full mummy makeover and lipo. I've lost around 5 stone. Well done, you, Amy. What's the secret? Tell us all the secret. So I think, yeah. So yeah, a full mummy. So maybe it's a bit not much to have your arms done at the same time, Amy, I would say. And also, not to mention, you know, it's a lot for you. The reason it's a bit much is a lot for you, for your body, you know, to be having all those cuts and scars and all that sort of stuff. Yeah. So Lowry J22 on Instagram has said, sorry, I have a question about breast reduction. Is it possible to have a reduction and a small high profile implant for the bust? Sorry if it's a silly question. No, less of the sorries, Lowry J22. I'm happy with their questions. Now, did I get round to this, Lowry J22? Because I didn't mean to do a write about this. You know what? Now you mentioned it, I don't think I did I? That was definitely my next blog post. Plus minus technique, whatever you want to call it. There is a technique where people do this, Lowry J22, where they do. I did write about it, didn't I? Oh man. Anyway, sorry, I'll check afterwards. Look at the blog, see if it's on the blog. But anyway, there is a technique where people talk about doing a reduction and then adding an implant for fullness. It is not a silly question because one of the limitations of a breast reduction, now a breast reduction does include a breast lift with it. That is standard part of a breast reduction. But one of the limitations of breast reduction and breast lift is that whilst they're full to start with, they do settle. And some people want a fuller look that you can get with a breast reduction or a breast lift. So even if you're having a breast lift, they do settle to what I say is a more natural result, but it does settle in the upper part of the breast. And some people say, I want to be fuller. The only way really in my hands to get fuller is to have a breast, is to have an implant. So I think that is a valid thing to say, look, I want to be fuller. I want to have more fullness in the upper part. Therefore, I want an implant. That is a valid sort of connection to make, that you know you want the implant to give you that fullness. The problem comes because implants make them bigger, obviously. So the problem comes when they're already too big because you want a reduction. So what you're saying there is what, as I say, some people do propose, which is over reducing and then adding volume back with an implant. So that is a technique for that very reason, to give you that fullness. Now, it doesn't sit well with me. I'll be honest with you, full disclosure, it doesn't sit well with me because I don't like the thought of taking volume away and then putting it back in, taking natural breast tissue away and then putting it back in the form of an implant. I do use a lot of implants, and I'm not negative. I'm not anti-implants, obviously, because I use a lot of implants. But if I can talk someone out of having an implant, or if we can get, you know, a result without using an implant, I would say to you it's better not to use an implant. You know, is it better to have an implant or not? Well, not basically, because implants can give you problems in the long term. Now, the problems are rare. You know, they are rare, but they're there and they can be a nuisance. You can get rippling, you can get capsular contracture, you can get rupture, you can get ALCL, that very rare cancer associated with implants, breast implant illness. So there are lots of things, they're all very rare, but they're there and there's something to worry about if you do choose to have implants. So I would say have implants if you're smaller, because I think implants are the best way to make them bigger. But if you're having implants just to give you a bit of fullness up there, I'm not sure if it's worth it. Now, it's not my body, it's your body. So you have to do what you feel comfortable with. But I would probably, and what I do is I talk to people more like saying, look, do you know what? Why don't we just do a reduction, see what you think about the shape? You may not be completely happy with the shape. You may have wanted it to be fuller, but as long as you're aware of what can be achieved and you're not, and you're going into it with your eyes open and say, look, you know, I know it's not going to be maybe quite as full as I'd like, but I understand that I need an implant for that. And those implants has potential for complications. You know, you might accept that compromise, and it is a compromise. It's always a compromise. You might not. You might say, you know what, I'm not accepting a compromise. I want the shape I want. Well, that's fine, but you're going to need to take on the risks and complications associated with an implant. And as I say, I don't like the thought of taking away healthy breast tissue and adding an implant. It just doesn't sit well with me. But anyway, it's definitely a technique and it's definitely out there. So it's definitely something people do. You know, probably not your first port of call if you want that technique, because I'm probably going to say to you what I've just said to you there, and be a bit more like, you know, why don't you just have the the reduction and see what you think. So maybe you want to find someone who maybe is a bit more of a proponent of that technique, because that ain't me. But yeah, I've been asked that quite a lot recently, so maybe I should. I've been meaning to write about it, but. Thanks for reminding me there, Lowry. Jay, so what we got? Natty, hey, JJ, my scars are quite raised at the moment. I know it's only a week post-op, and I know it's a silly worry. Not a silly worry, Natty. Not a silly worry. But don't worry. So, yeah, I mean, scars being raised are a thing and something we worry about in terms of what we would call hypertrophic scars. But hypertrophic scars are something that happens weeks, actually probably months down the line. So at a week, don't worry. And actually, the way that we suture is we evert the wound. We try and make the wound like that. Invert the wound edges, yeah? Because you want the maximum contact for the maximum healing. So sometimes wounds potentially can look quite raised, but actually that's a good closure. So you want a closure where it's everted. You certainly don't want it inverted, because if you have it inverted, that's skin on skin. So if you've heard of people who, you know, I sometimes see people have a mole or something like that, mole, the stitch is taken out and then it dehisces, it opens up, and they think, oh, it's because I coughed, or because I did this, or because I did that. It may be because you coughed, or because you did that, or because it was closed tight, but it may be that the wound edges were inverted. If the wound edges were inverted, when you take the stitches out, that's just skin to skin. That's not going to heal. So you need to evert your wound edges, and it's actually quite difficult to do when you're suturing. One of the, you know, when you first start doing plastic surgery, one of the first things you do is you learn how to suture, and that involves, you know, making sure that you're everting that wound. And it actually, when you start doing it, it can look quite awkward as a surgeon, the way you do it. And you know, if you're sort of in A&E and you're stitching someone's arm up or something, you might want to look slick. I know what I'm doing, you know. But actually, if you try and put the stitches in properly, you have to really get that needle back down at 90 degrees and then pull the skin up and evert, so your wound is everted. So basically, don't worry, Natty. A week, I think it's fine. But if you are worried, hold on a minute, you're worried. So how can you see your stitch? So presumably Vicky's taking the dressing off today then, presumably. So what did Vicky say? Yeah, I mean, I was going to say, send us a photo, and I thought you still got your dressings on, but you obviously haven't, because you can see your scar. So anyway, send us a photo, or just ask Vicky, because she saw it today, and Vicky knows what's what. But yeah, if they're a bit like that, it's not a bad thing. Sophie Sinclair says, good evening. Good evening, Sophie. Lovely to see you here. What we get? We got Danny. Where, in comparison to a C-section scar, would a mini tummy tuck scar be, and are they similar in size? Danny, it will be in the same place as a C-section scar. So when we do a mini tummy tuck, when you've got a C-section, and it's quite common for people to have a C-section, is we go just below it, just below your C-section, and cut out your C-section scar, and then do your mini tummy tuck. So you end up. The aim is for the scar to be in the same or similar place as your C-section, but it's usually a bit longer. So it is usually a bit longer. A mini tummy tuck scar is longer than a C-section scar, but in a similar place. Dr. KTK, hashtag Ask JJ. You're listening, guys. Dr. KTK is in there. What are we, 20 minutes in? First person to get the hashtag in. Come on, team. You can do better. You can do better. You can do better than that. Anyway, well done, Dr. KTK. Thank you for that. Doctor, what is your view on the injections used to use fat for areas with stubborn fat, like double chins? Burn. What is your view on the injections used to use fat? Oh, burn fat, is it? Instead of burn fat for areas of stubborn fat, like double chins. I don't know, Dr. KTK. I mean, it's an area I don't know anything about, so I'm not. I don't know. Sorry, I don't know if they're good or bad. It sounds a bit. So what, you inject and it burns? What injections to burn the fat? Doesn't sound good to me, Dr. KTK. To be honest with you, I'm bordering on layman's knowledge on this because I really don't know anything about it. But it does. It just. I mean, the worry is like when you do liposuction, where if you stick a liposucker in and try and take the fat out from areas wherever it may be, you worry about the contouring and the shape. You have to feather it and you have to make a nice shape. So injection, how can you control which fat that? Surely that's going to give you dents and lumpiness, I would imagine. But again, it's like anything. I'd say, look, find someone who's doing it. If someone's doing this sort of thing and they're getting good results, and it's an acceptable treatment. I don't know if it is an acceptable treatment, to be honest. I want to be careful what I say here. I don't want to be condoning some. I never know what condoning is. Condoning means supporting it or going against it. If you condone violence, does that mean you go against it? Or you don't condone? Anyway, whatever. Let's not use the word condone. Let's just say I don't want to be supporting something that's a dodgy treatment. It sounds like a dodgy treatment to me, to be honest with you. But I shouldn't say that because I don't know anything about it. So there might be some very reputable people out there doing it, getting great results, in which case, great. But sorry, Dr. KTK. Thanks for the hashtag. Sorry, I haven't answered that question very well at all, have I? Let's move on, shall we? I'm losing followers. I don't think I am. I need to start off with it. Anyway, no. 9 and 5. Oh, 4. I did lose one. Damn, I shouldn't have said that. So I'll come back. I can't right now. Thank you so much. Really appreciate your feedback. Oh, thank you. Yeah, that's exactly the appearance. I feel better for mentioning it. Vicky was pleased. There you go. Apparently, injections are local and subcutaneous and achieve fat burning. Sounds a little bit. I would worry about how well you can contour it with an injection because it's hard enough to contour it with a liposucker. A chemical that metabolizes fat. Very odd. Yeah. I mean, it sounds good, Dr. Katie. I mean, if it, you know what, much as surgery is the thing that I've spent all my life trying, well, not all my life, but, ages trying to, work out how to do. If there's stuff that you can do without surgery, fantastic. I am, contrary to perhaps popular opinion, I am absolutely all for it. This non-surgical liposuction, there's that stuff you can put on top to burn, to heat the fat and to cool the fat and to radio frequency the fat and all sorts of things to sort of put on the body to sort of to destroy the fat without needing to put a liposucker in. In principle, I am all for that. If you can do something which doesn't involve sticking a tube in and sucking it out and all the complications in terms of anesthetic and stuff, I am 100% all for that. So if there is something, the injection thing, if it's, less risks and gets the same result or acceptable results, let me know. I'll be all over it. I'd be happy just to do little subcut injections. I'd be very happy, to be honest with you. I've done surgery, done that, been there, done that. It's subcutaneous injections. That'll do me from now on. But I'm not convinced. Now, Marima Asli Marima Asley has asked again, requested to be in my live. Shall I just say yes? Do you want to? Does that mean you want to be split screen with me? Have you got a question, Marima Asley? Marima Asley. If you got a question, we can do split screen. But I don't want to press yes and then you go like, oh, it's gone. Oh, right, you didn't. Oh, I don't want to just appear in your living room for all 7 people to see. Then you might be a bit embarrassed. I'm used to it now. People coming into my living room. Well, that's the office, the study. Right. What we got? I'll tell you what we got. My mole I've had since a child has suddenly become itchy. Should I be worried? Yeah. Yeah. Now, I say be worried. Maybe being worried is probably the wrong thing. Should I seek help? Yes, you should seek help. I mean, you can't mess about with moles. I mean, we worry about melanoma. Melanoma is a bad skin cancer. So we worry about moles that are changing. So what we normally say to people is to look out for a change in your moles. So a change means if it starts bleeding, if it starts itching, if it changes in size, that means bigger or smaller. If it changes in shape, if you get anything like a halo around the outside or other little moles around it, these sorts of changes are things that you need to seek help. Now, it doesn't mean it's definitely a melanoma. It doesn't mean it's definitely gone bad. So I don't think you should worry in that respect. I don't think you should think, oh my God, I've got melanoma. But I do think you should get it looked at. And sometimes people say, we say, look, if it bleeds, if it itches, if it changes in size, all these things, then, you've got to get it checked out. And you'll come and we'll have a look at it and say, yeah, that's fine. And you'll be like, yeah, but you just told me if it changes in size, shape, and all that sort of stuff. Yeah, if it does those things, get it checked out. We're not saying it's a melanoma definitely just because it's changed in size or just because it's itched or just because it's bled. Doesn't mean it's a melanoma. Other normal benign moles can sometimes do these things. You can catch it, scratch it, bleeds, sometimes it gets a bit itchy, they can be a bit raised. So they can change in size. So it doesn't necessarily mean it's a melanoma just because one of those things has happened, but it does mean that you should get it checked out. Now that means you can come and see us, no problem at all, or you can go and see your GP, who'll be able to give you an idea of what's what. But if a mole has changed in any way, so in this case become itchy, yes, I think you should get it checked out. And depending on where it is and the size of it, it's often a case of just saying, look, should we just do an excision biopsy? Should we just take it off, and then we know what's what? But sometimes we can say, look, it's clearly fine, nothing to worry about. But yeah, how do I know if I need either a mini or a full tummy tuck? Well, you ask the surgeon. I think there's a lot of this nowadays. People sort of, and I guess it's only going to get, I suppose worse is the wrong word. It's only going to get more common for people to come requesting treatments, like fat dissolving injection or mini tummy tuck or things. But really, to be honest with you, as a patient, your job is to say what result you want, what you're trying to achieve, what the problem is, and what you're trying to achieve. And then our job as doctors is to know about all the available options. Okay, I didn't know about the fat injections. But anyway, is to know about all the available options and then to make a balanced decision on what's right for you, to give you advice about what might be right for you. So I don't think you need to worry too much about thinking, should I have a mini tummy tuck or a full tummy tuck? How do I know? It's like saying, I'm unhappy with my tummy, so I need to go and see someone to see what is the best thing for that. And, some people are not candidates for a full tummy tuck. If you can't get the skin closed from above there to down there, you're not candidate for a tummy. So if you haven't got much skin, you haven't got much excess, you might not be a candidate for a full tummy tuck. And that's something we probably need to assess in the clinic. If you are a candidate for a full tummy tuck, then I guess you could have, pretty much anyone could have a mini tummy tuck. You could have nothing. I mean, a mini tummy tuck will do more than nothing, but not as much as a full tummy tuck. So it depends on how much you want to achieve. So it's really something you need is a discussion with the surgeon, and we can say to you, look, you know what, a mini tummy tuck. I mean, a mini tummy tuck basically addresses the lower abdomen below the belly button. So it addresses a fullness below the belly button. It doesn't really do anything to the sides. It doesn't do anything to anything above the belly button. So you can't repair the muscles, and it doesn't do anything to any slack skin or fullness in the upper abdomen. A full tummy tuck will go all the way above the belly button, will tighten the skin across the whole of the abdomen, and further out to the sides. And at the same time, it is possible to repair the muscles with a full tummy tuck. It doesn't do a great deal to the hips and flanks, which can be addressed with liposuction, which can be combined with a full tummy tuck. So it depends on what sort of results you're trying to achieve, and it depends on how much laxity you've got. So really, I would say the answer to that is, you're not expected to go to a doctor, to a surgeon, knowing whether you need a full or a mini tummy tuck. It's good to do research and see what's out there, but to get advice from a surgeon who does mini and full tummy tucks is what I would say to you on that one. Do textured implants have a slower rate of capsular contracture? Compared to what? Compared to smooth implants, yes. So smooth implants are sort of like glassy smooth, and what happens is that scar tissue forms around that implant, and then when it contracts, as it always does, so everybody with implants has scar tissue forming around it, has a capsule. That's normal. That's the body's reaction to having an implant put in, and in time that capsule contracts. Now, if you have a textured implant, that surface is not glassy smooth, it's rough. And there's two types, there's micro and macro textured. Macro textured is more rough than a micro textured. The rougher it is, the more it breaks up that scar tissue around the implant, so that when it contracts, it doesn't contract as a sheet, it contracts in different directions. And then above that is a polyurethane implant, which has got a foam coating where the scar tissue actually grows into the foam in all three different directions. And so when that contracts, it's much less likely to go hard. So a polyurethane implant has the slowest rate of capsular contracture. A textured implant is second, and then a smooth implant is third. You can put micro textured in between textured and smooth, but yeah, the more rough they are, the less or the longer it takes for the capsule to harden. So the less the rate of capsular contracture. But ALCL, that type of cancer associated with implants, very rare, but it seems to be related to the roughness. So it's the flip side with the ALCL. It's more common with the rougher implants than the smooth ones. So it's a balance. But yeah. Danny, what did you got? I've got a consultation with you the end of this month. I know you have stopped doing money makeovers recently. Have they started again now? Danny, good question. Sort of. Sorry about that. So they have sort of started again, Danny. It's sort of a case by case basis, really. So it's not a carte blanche, but yes is the answer. It's relaxed, and there is scope to be doing combined, to tentatively start doing combined procedures, Danny. Yeah. So yeah is the answer. Sort of. So hopefully it stays that way, and we'll be able to carry on. If I get pregnant, would I need to have my implants removed? No, not at all. Fine to get pregnant, fine to breastfeed, assuming you could breastfeed before. Having implants is not going to affect your ability to breastfeed. It's absolutely no problem. So absolutely don't worry about it at all. If you've got implants in and you're thinking of getting pregnant, do not worry about it at all. The only time it becomes an issue is if you haven't got implants in and you're thinking of having implants in and you're thinking of getting pregnant. I would say to you, wait until you've finished your family, because having children can affect the size and shape of your breast. They can droop, they can get bigger, they can get smaller. So I would say wait. So if you've already pulled the trigger and you've already got implants in, well, yeah, getting pregnant can affect the size of your breasts and the shape of your breasts. But what are you going to do? Just, see what happens. That's what I would say. Don't worry about it. See what happens, and it might be fine, it might not, and you might need something doing, but you definitely don't need your implants removed, not at all. No. People worry about silicone in the implants, but there's silicone in those little plastic teats, for the bottle. So don't worry about that. How long post breast surgery can I have a bath? So usually / always, well, yeah, you'll have a dressing on for a week, depending on what breast surgery. So breast implants, I do put a waterproof dressing on, whereas breast lifts and breast reductions, it's not waterproof. So breast implants, you can not have a bath, but have a shower early, straight off. With breast reduction and lift, you have like tapes on, so you can maybe sit in a shallow bath, but you don't really want to get the tapes wet. After a week, the dressings will come off. To be honest with you, it's probably better to have a shower after a week, because you don't want to be sort of sitting in a bath, like sort of, if you've got a bit of an ooze and that's, staying in the water. So if there is a bit of an ooze or the wound's not quite sort of fully healed, I would go with showers where it's constant water. So maybe 2 weeks, 3 weeks, depends on how long it takes for that ooze to settle before you can have a bath. I mean, if it's all dry as a bone at 1 week, then yeah, you can. But maybe 2 or 3 weeks, probably safer, and maybe do showers until then. In general terms, that's what I was saying. What we got here? What's going on? What have I missed? Have I missed stuff? I don't know. What have I missed stuff? Here we go, Danny. I've got. Oh no, I've done that one. I missed any. Oh, Meg, do you recommend taking arnica to help with bruising? Well, no, that sounds bad, doesn't it? No, I don't recommend it, Megs. But a lot of people say it's good, so I don't sort of not recommend it. I don't. What's the opposite of recommending it? I don't warn people against it. There's nothing wrong with it. And I've been thinking about recommending it, to be honest with you. The thing is, I don't get much bruising, but occasionally you get someone who gets bruising and says about arnica and things, and I think, oh, crikey, maybe I should have told them before. I don't know. So I don't think it does any harm, Megs. So whilst I don't recommend it, if someone says, should I, can I take arnica? I'll be like, yeah, of course you can. Yeah, take arnica, that's fine. So, don't recommend it, but by all means. The reason I don't recommend it is because, as I say, bruising is not a massive problem. I bruise terribly. Well, if you bruise terribly, Megs, go for it. Yeah, go for it. And as I say, maybe I'll be interested to know if it helps, because if it does help, maybe I should be recommending it to everybody. Amy Maddox 9. How long is that's annoying, Amy Maddox? Is there 8 others who've got the Instagram name before you? How annoying is that? How long is the wait roughly from having consultation to the procedure? Well, Amy, it depends on what it is. So if it's a mole removal, we do the procedures there and then. If it's a bigger op, like a breast reduction or GA case, like a tummy tuck or something, then it is what are we saying? I think we were saying we're booking June maybe, or July. What are we now? April, May, June. A couple of months, I think. I don't really know, to be honest. I think it's that. I'll be honest with you, Amy. I got enough on trying to get these operations right and worrying about all that stuff. And I got no idea when the next operating list is and stuff. No idea. I haven't got a Scooby Doo. But Megan and Nicola and all that at the clinic, they're all over it. They know, they could tell you bang on to the day the next list. I bet. I'm going to say a couple of months, Amy. Should we just say a couple of months? Leave it at that. If you want to be specific, if you're really interested, get on the blower or Instagram me, and Megan will pick it up and say it'll be next list is whatever. Sorry, I don't know more accurately. What's Hannah Risoda got to say? Hannah Risoda, hello, can I ask how you correct asymmetry with implants? Thanks. Well, Hannah Risoda, you use a sizer, Hannah. And the first thing is, everybody's got a bit of an asymmetry. Everybody, like 100% of people. And so if it's a significant asymmetry, and I'm thinking, the question is it enough for different size implants? Because the problem is the implants come like, 200, 240, 275, 315, they don't come like every size, it's not infinite the sizes. They come like with, 30, 40, 50 cc's between them. So sometimes you worry that if you put a bigger implant in the smaller breast, you'll make it too big. So what I would normally do is I choose to put an implant in one breast. I choose one. So I'm going to put that implant in one, and then I'm going to use a sizer in the other to see. So a sizer is like an implant, but it's a throwaway one sort of thing, to see and think, crikey, that's too big there. let's go a size down or something, you know. So so if you can picture it, so if you've got, let's just say 240, so you put a 240 in one, and let's just say you had an inflatable sizer. There used to be inflatable sizers. They don't do inflatable ones anymore. But let's just say you had an inflatable one and you inflated it and you got to 254 cc's and it's perfect. 254 is perfect. Now, the problem is I've got another 240 or a 270. I haven't got a 254 cc implant. So I got to decide whether I put another 240 in and it'll be a bit small, or I put a 270 in and it'll be big, too big, bigger than the other one. So that's what we're up against, Hannah. We're up against an imprecise science. So that's what we do. We use sizes in theatre to see, to judge, but it's always, what I say to people is there's always going to be an asymmetry, and even if you put different size implants in, there might still be an asymmetry. It might still be bigger, or it might actually be smaller. The bigger breast might be bigger, still be bigger, or it might be smaller than the other one. But we're trying to balance things up and we're trying to make it better. So that's what we're trying to do. We're trying to make it better, but it probably will still be asymmetrical. The other thing I'd say, Hannah, is that when you have an asymmetry, even if you use the same size implants, the asymmetry gets swallowed up a bit. And actually, it's better. So a lot of people don't even realize they've got an asymmetry. I always point it out because I don't want to be blamed for it afterwards. But if you don't even realize it pre-op, often when you make them bigger, it swallows it up a bit. The example I give, if you think about it, if you've got one breast that's 50 cc's in volume and one breast that's 100 cc's in volume, so one breast is twice as big as the other. If you put 400 cc implants in, you'll have 450 cc's and 500. So the difference will just be 50 cc's. So it's only 10%. So before you had any implants in, it was 100%. One breast was twice as big as the other. But when you put 400 cc implants in, one's 450, one's 500, it's only 10%. So proportionally, the difference is less, even though the absolute difference is the same. Don't want to get too technical. Don't want to get too mathsy here. Not what we're here for. But basically, we're just trying to make asymmetries better. But there'll always be some degree of asymmetry, bottom line. But yeah, that's how we do it, Hannah. That's how I do it. I think how most people do it, I assume. I don't know. Anyway, that's how I do it. Bath, we've done that one. Oh my God, I'm on the last one. I'm on the last one, guys. So get your thinking caps on and get your questions in, because this guy is on his last question. Okay. When can I drive post-surgery? Will prescribed medication stop me from driving? Again, kind of depends on the op. So I'm assuming it's a big op. I mean, let's be realistic. It's probably going to be a GA case or a bigger case. But just to what do they say? Just to tail it off. Anyway, for smaller ops, minor ops. So strictly speaking, for minor ops under local anesthetic, so if you're having a mole removed, strictly speaking, you shouldn't drive for 24 hours after the local anesthetic. That's what they say on the stuff on the local anesthetic. So that's for 24 hours. But that's the local anesthetic. But I think for if I'm assuming we're talking about sort of breast augmentations and things like that. So it is a good question to ask, because you don't really want to be driving to the hospital and then thinking, hold on a minute, how am I going to get home? So you really want to be not driving home. And it depends on how well. First of all, prescribed medication will not stop you from driving, because the medication that I suggest after surgery is usually ibuprofen and paracetamol, which is not even prescription medication. We can give you stronger ones like cocodamol, codeine phosphate, codidromol, but I normally say to people to avoid those if you can. So that is not going to stop you. The medication is not going to stop you. The thing that will stop you is the surgery. So I normally say that, but it's really what it is. Obviously, a breast augmentation is less than a breast reduction, for instance, and a breast augmentation on top of the muscle is less than a breast augmentation under the muscle. But after a week, for some cases, like maybe a breast augmentation on top of the muscle, for instance, possibly one under the muscle, you may well be able to drive after a week. It's hard to be too specific to everybody because everybody's different. So I would probably say, to be safe, say 2 weeks. If it's a bigger op, like a tummy tuck or a bigger breast reduction, that might be 3 weeks. Now, you might need to check with the insurance company, because they might have a set view that it's got to be 3 weeks after surgery or something. or they might say it's up to the doctor, in which case, we'll see you at the dressing clinic at 1 week. And as I say, 2 weeks is sort of normally safe, but for bigger ops like tummy tucks and bigger breast reductions, 3 weeks might be safer. But as I say, everyone's different, so it's hard to be too prescriptive on that. Hannah's giving me a thumbs up. Thank you, Hannah, as has Amy and Megs. Thank you. I do acknowledge those things, but I'm not supposed to acknowledge them while I'm answering the question because I've been told off that sounds distracting when I'll say, oh, thank you, Megs, thank you, Amy, halfway through the answer. So I've got to try and train myself not to do that because we're all learning, aren't we? Learning process. Katie Sarah, how long do you have to wear the pre-op bra for after BA? Not a pre-op bra, Katie, it's a post-op bra. Pre-op will be before. So in my hands, 4 weeks, sometimes 6 weeks for a teardrop implant, but 4 weeks, broadly speaking, day and night. Now, if we're going to get some sunshine, although it's been snowing today, would you believe? But if we are going to get some sunshine, sometimes people think, oh, thank God for that, let me get into a normal bra. But if it's not, the weather's not really, great, and sometimes people quite like it and they want to wear it for longer, that's absolutely fine. You can wear it for longer. Things will be swollen, things will be uncomfortable. The shape won't be quite right for a few months. It takes a few months, really. It takes about 3 months before things really start to settle. So, but I think it's quite a big deal to say wear the bra for 3 months. So I normally say 4 to 6 weeks. And then see how you go, and you can start wearing normal bras. And if you wear a normal bra and it hurts and it swells, then go back to the supportive post-op bra. So a month is normal. Sorry about the hound in the background. So they're watching a movie apparently. So if there's no other questions, I'll go and see what they're watching, and perhaps I will join them. But if there are questions, I'm very happy to answer them. I'll tell you what, if you've got a question, what you can do is you can, thank you, Katie. What you can do is you can message me and I'll answer it, and we can do it next week if you want. Next week. I think, yeah, next week. Yeah, that should be good. So happy Easter. Sorry, I haven't said that. Happy Easter, everybody. Hope you had a lovely Easter weekend. And I will see you same time, same place, 7 p.m. Tuesday night. Get your questions in. Thank you for those questions tonight. Thank you for interacting, everybody. Amy, Hannah, Katie, Megs, Danny, you name it, Dr. Katie, Natty, thank you all. For Lowry J, don't forget Lowry J. I shouldn't want to start. I don't want to miss anyone out. Anyway, that's fine. Thank you all for your comments and suggestions. Stay safe, Jackie. Big up yourself. Staunch supporter, keeping the numbers up. I'm going to check myself out and go and see what film they're watching. And until next time, I will see you again.